equipment to wear during the procedure will be wearing non-sterile gloves, a mask, and a cap. So make sure you wash your hands really well. Nice to set up the bedside table for the doctor. So what you'll need to do is ask them what size sterile gloves they wear. Bring them a surgical gown, sterile towels, a mask, and a cap. Like we talked about, the Camino Bolt box, which is usually a green box, but make sure you read it. It says Camino Bolt. And a cranial access kit. If the patient has a lot of hair, you'll also need to grab the surgical clippers and a razor. The things you'll need for an ICP bolt insertion is a cranial access kit, which is a big white box. You'll need the Camino, and you have to make sure you have all the cables for the Camino. So you're going to need to have the cable to make sure that it slaves to the monitor. So this will be connected to the back. So you'll see a monitor cable that will have also what looks like a pressure cable, but you'll need an adapter for it to connect to the monitor, which is a smaller adapter. You'll connect this cable to the smaller adapter. Make sure it screws on. And then this will connect to any pressure module. You'll also need to have the cable that will monitor the pressure. And so it's most likely going to be a black cable with a box to it. You'll know that it's for pressure because it'll have P, and then you'll see a red line right here,
Okay.
and you'll need to line up that red line to the red arrow. So, as so. You'll see this black box will be connected to the patient's bolt once the doctor inserts it. So right now I have the Camino on a IV pole, but you can also place the Camino on a bedside table as long as you have enough slack for the cables to connect to the patient. So make sure you have enough room that when you turn the patient, there's still enough slack and that nothing gets pulled. So I will show you the key functions of the Camino. To turn it on, you press the start stop button and the screen will automatically populate. You will not see a waveform yet because we're not connected to a real patient, but I'll show you what each key is for. So when you press scale, scale is just gonna give you a, can either increase your scale so that you'll see a better waveform if the ICP is high, or you can make the scale smaller so that you can see that the waveform if the ICP is a little bit less. But you keep pressing scale until you see a very good waveform. As for cow step is when you want to slave the Camino to the monitor. And so by doing that, you would take the Camino cable to the monitor and you'd connect it to any of the pressure modules. So we'll connect it here. Once you connect it to the pressure module, you want to make sure that you change it so that the label is going to read ICP. You'll see a waveform, but you have to make sure that it's labeled ICP. So by changing it, you'll click on the waveform itself. And click on the label, change it to ICP. And then you'll see the waveform show and the ICP number show as well.
My name's Marco Lee. I'm a neurosurgeon, and we're going to talk about inserting either an external ventricular drain, or often abbreviated as EVD, or an ICP bolt, and they're two different things, but they very much do similar things. So we normally find patients who have traumatic brain injury or any other concern, and we require a measurement of the intracranial pressure. Sometimes we also want to drain cerebrospinal fluid from the brain, from the ventricles, and that's also something that we can do with the EVD, but we cannot do with a bolt. So an EVD is just a catheter that's inserted, just a tube inserted into the ventricle, usually in a non-dominant hemisphere or away from site of infection. So for most people that would be the right side. And that's a tube that's connected to a bag and it drains fluid. That fluid can be transduced, the pressure can be transduced, so we know the pressure, the intracranial pressure, and at the same time we can drain CSF. We can drain CSF to bring down the pressure, we can drain CSF to get diagnostic tests done as well. And an ICP bolt is more like just a wire, it's not a tube, and it measures intracranial pressure, but it's not therapeutic in the sense that you cannot drain fluid. And sometimes that's used in preference to an EVD, especially in situations where the ventricles are very, very small and slit-like. An ICP bolt has the advantage of lower complications. There's very low risk of hemorrhage and very low risk of ventriculitis, which is an infection or an inflammation of the ventricles, and that you see in EVDs more so. So let me introduce you to a few things here. For both an EVD or the ICP bolt, you'll need a cranial access kit. This comes with a box like this. In it, it has a twist drill, which comes with a drill bit. It's handheld, and obviously an EVD, which takes a tube, will have a larger drill bit, and that drill bit can be found in the cranial access kit. For an ICP bolt, it's very small because you're just passing a wire, and the actual drill bit comes with the ICP bolt kit. So the actual smaller drill bit is in here. The types of EVD that you can use, usually for a patient with trauma, we use a trauma catheter, and it's actually conveniently labeled as trauma cath. But for other neurosurgical procedures, for other neurosurgical conditions, that's not necessarily traumatic. It's not necessary to put a trauma cath, which is a larger diameter, so it's a little bit bigger, so the risks are bigger for hemorrhage and infection as well. For other conditions, we may actually opt to just use an EVD and not a trauma cath. And an EVD has a smaller caliber, and some of them are impregnated by antibiotics, and they appear not white or clear in color, but it is orangey in color. So this is an example of one of them, and we'll open the boxes and show you what the contents are. So for a cranial access kit, comes in all sterile. So the person doing the procedure will need a table because there's a lot of gear, and we need a free table that we can wheel close to the patient so that it's like our operating tray. And obviously the procedure has to be done sterile. There are a few things that we can do prior to opening all this up in preparing the patient. So before I show you all these things, maybe I should show you how to position a patient. So to position a patient, we're going to be standing at the head of the bed. And so whatever you can do to make it easy for us to access the head of the bed would be much appreciated. Especially we need to keep ourselves sterile, and it's very difficult to maneuver ourselves under the tubes. This is a modern ICU, and we can actually get behind quite easily because of these movable instruments. But in the older ICUs, there's a lot of tubes around and catheters, so just something to bear in mind when you're preparing for the provider. You can actually help maneuver them behind the patient. The next thing is that the patient's head ought to be flush with the bed. So if they're slumped all the way down, you need to pull them up so that the head may even be sticking a little bit out from the head of the bed. And the bed should be elevated. It differs. Some providers like it at 45 degrees or 30 degrees. I'm not too fussed about exactly how it is, but it should be elevated and convenient, and the bed elevated to height that's convenient and safe for the provider. All this is done non-sterile, as I said. The patient head should be shaved, so if you can find us a shaver, that's preferable to a razor. A razor is traumatic, it causes scratches on the scalp, and it can cause infection after that, so it's not ideal. What would be ideal is
surgical clipper.
What would be ideal is a surgical clipper like this. So, what I would do normally in a non-sterile way is I would make sure that the patient is well positioned. I would make sure that the patient is not coagulopathic, so we should definitely find out that his INR and PT, APTT is normal or not too abnormal. We should give him some antibiotics beforehand, preferably. Typically ceftriaxone if there's no allergies. And also we need to make sure that the patient is suitably comfortable. So sometimes we do these patients when the patient's wide awake, so we have to use local anesthetic. More often than not, the patient's actually, their conscious level is reduced, and so pain is not so much of an issue, but we sometimes still use local anesthetic, or we ask you to give them more sedation, such as propofol. So we shave the hair. We usually, as I said previously, we choose the right side. It's the non-dominant hemisphere for most people, but occasionally it's important for us to find out that the patient is, for example, left-handed and knows that his right hemisphere is dominant, so we try and avoid that. But all things equal, we always do the procedure on the right side of the head. We shave, we then prep. The prep can come from the cranial access kit. It has betadine in it, or you could prepare us a Duroprep or chlorhexidine if they're allergic to that, or alcohol, but something that we can prep the hair and the scalp with. And then we're all ready to gown up. When we gown up, we need at least a gown and sterile gloves. Some providers would like a cap and a mask as well. I tend not to do that because there's no evidence that that's needed, but some out of habit would like that as well. So we open the cranial access kit. Let me show you what is in the cranial access kit. So when we open this, obviously it's non-sterile, and once it's open from this package, so you could be doing this for us, and then let me put on my sterile gloves. Okay, so you'll be able to help us open this package, and this person who's got the sterile gloves on can then take this, which is all sterile, and then we can open this kit up. this is the cranial access kit. And the cranial access kit is needed for both an external ventricular drain insertion or an insertion of an ICP bolt. The most important part is the actual drill, but it also has a few convenient things. It does have a razor in most of these cranial kits, but as I said previously, the razor can cause scratches and it's a high infection risk and traumatic, so we prefer a surgical clipper. It also has syringes in it already, so that you can load local anesthetic. It's got the needles provided, as well as a long needle that can be used to pierce the dura, and I'll show you when we need this. It's got some cups so that we can have our betadine in. It's come with some sponges, not too many, so sometimes we ask you to give us some extra sponges. And importantly, it has this drill bit. This drill bit is the one for the trauma catheter. The drill bit comes with an Allen key, and the Allen key is to move and position the stop. If you can imagine, if we didn't have a stop and we're drilling, we might plunge the drill bit into the brain, which is not ideal. And that's why we have the stopper, so that even if we plunge, which can happen, even if we plunge, it will stop and it can't really hurt the brain. So this is an ICP bolt. Now, this depends on the company that we use, but traditionally we have been using the Camino bolt, and this particular one is a green label. There are ones which come in different colors, black label being another one. They all do slightly different things, but vast majority of the cases we use the green label one. So when we ask for an ICP bolt, pretty much you can assume that it's the green labeled box that we want. So again, it's a non-sterile box. You would open this for us. I would have my sterile field, and you would hand this to me, and this is sterile. And as I open this, there are a few items that's different from the what we find in the cranial access kit. We still need the cranial access kit, but the bolt, that the drill bit that comes with the cranial access kit is not the drill bit that we would use. So the ICP bolt comes with its own drill bit and its own stopper and Allen key. So it's similar in the sense that we move the stopper down to the required distance so that we didn't plunge into the brain. We connect this to the same twist drill as previously shown, and as you can see, it's a much smaller caliber. So the actual bolt is this. It doesn't measure pressure. We call it an ICP bolt because you bolt this down on the skull and it sits on top of the skull. And the actual ICP monitor, depending on the type of monitor, it's just usually a wire. And the tip of the wire is what measures the pressure. The wire is very fragile. If you bend it, it can break the wire or give an erroneous message or data. And what happens is that if the bolt is bolted in here in the skull, you pass the wire through. So this is the bolt, and what happens is when you have this bolted onto the skull, you pass this wire through, and as you can see, the wire comes out, and you have to make sure that it's actually well past the tip of the bolt itself, so that it's actually sitting in the brain to measure accurately the pressure. And how do we know that it's actually far enough and not too far in? Well, if you look at the shield here, there's a little clear window, and there's a little red dot here. As long as the red dot's within this window, then it should be in a good position. If it moves out, you can see the tip, how the tip, as we move the red dot out, the tip disappears into the bolt. So it's no longer in the brain, it's no longer measuring accurately the pressure. It will still give you a pressure because it's still measuring the CSF around that subdural space, but it's not accurate. It should be well within that window. If it's too far in, well, it's still measuring pressure, but it's probably not necessary, and it could cause harm if it's too far in. So we try and avoid that. So the sweet spot is around here. So for an ICP bolt, there is a few things that you would have noticed. It obviously has to be connected to an ICP monitor, in this case, the Camino monitor. And I'm holding a sterile part, and the other end would be non-sterile, so you would have to hold up the other piece so that we can plug this in. Once it's plugged in and switched on, we have to zero the monitor. People do it differently. Some, like myself, I zero it with atmosphere. Some would dip it in saline. I think the difference could possibly be 1 to 2 millimeters of mercury, so not significant. But when we zero, we use this little screwdriver, and there is a little screw here for us to zero it. Other more modern ICP bolts, you just have to press a button. So when you see this video, it may be antiquated already. But for now, we use a little screwdriver. And this screwdriver, we very often at the end of the procedure, we say, please take this to the monitor. And it stays with the patient so that you can actually, if there's any worry about the bolt, sometimes they can become inaccurate and need to be zeroed again. We don't have to open a brand new kit. We can just use the screwdriver that came with this particular kit. So now we're going to put an ICP bolt in. The procedure to start with is very similar to preparing a patient for an EVD. Make sure that the patient has access to the head of the bed, the patient's head is elevated and flush or slightly protruding from the head of the bed, the hair is shaved and prepared, typically using betadine. The shave is normally less because we're not tunneling any tube, and we're making a smaller incision because we're only needing a placement of a bolt. So once everything's prepared, the twist drill is again used to make the hole, and again the twist drill bit is smaller, but nonetheless it has the same danger as a larger twist drill bit, and as we're drilling, the patient who may be only semi-conscious or quite alert may start sitting up or using their hands to stop us. So it's very important at this stage for your assistance. So again, we would ask the assistant to work under the sterile drape, make sure that the bed rail is down so that you don't hurt your back, and hold the patient's head via the angle of the mandible. And then as we drill, we pierce the inner table of the skull, and we try and make a hole in the dura. If there's no hole in the dura, then we use a small needle that comes with the kit again to pierce the dura. Once that's ready, we then screw in the bolt, which is just a bolt in itself. It doesn't measure the ICP, it's just a channel, and this sits with the head. It usually in real life sits like this, but in this mannequin, I'm just going to let it dangle in the hole. And then the assistant can relax once the bolt is placed. The next important thing is for the assistant to switch on the communal monitor. So the bolt's been placed, but the wire has not been inserted yet. Because prior to insertion of the wire, we need to zero the pressure. So I would ask the assistant to switch on the monitor, which Marianne has just done. And we then need to connect the sterile part of the monitor to the non-sterile part. And there is also a little clip that can be attached to the bedside, which is important because, again, we don't want the wire to fall and then pull out the catheter unnecessarily. So I would ask Marianne to just please clip on to the side of the bed and to take up the slack with it. That's great. So now we can just rest this down. As you can see, in atmospheric pressure, it's reading 1. When we zero, we can zero it either in air or in a bit of saline. The difference is usually just 1, and sometimes I skip the saline and just zero it in air. To zero it, I use this black screwdriver. The black screwdriver is used on the screw, and as you can see, when I put the screw, if you look at the monitor, I can make the pressure either go up or go down. And the idea is to make it to go to 0. As you can see, this can be a little bit finicky. So now that it's zeroed, so I use the black screwdriver on the screw to zero the reading. This process can be a bit finicky. And once it's zeroed, I'm now ready to put it into the bolt. So now the bolt is zeroed in air or in saline, and it can be then inserted into the bolt, secured, and the red dot is in the window as described previously, so that it's in an optimal depth, and the lock here also secures it so that the catheter doesn't get pulled out easily. However, the catheter can still be pulled out, for example, if the patient suddenly wakes up and they move around, or whilst we're caring for the patient. So now that the procedure's done, we like to dress the wound. Even though the wound for a bolt is very small and it's most likely to be covered by the bolt, we still try and keep the opening sterile. Everyone has their own preferred way. I like a fairly easy and neat way. I take a sponge, I wrap it along the length of it, dip it in betadine, and I just wrap this around. This is wet when I wrap it, and as it dries, it cakes around the wound and provides a good barrier. If you find that this is coming off, you could easily do the same yourselves. There are several ways to secure the ICP wire. One I like is to make a bend like this. Again, it just takes up some slack, and I tape this to the plastic covering. I make sure that I do not block the window.
After puts in the ICP bolt, you'll see a perfect waveform, hopefully, on the screen on the Camino, and you'll have an ICP number. Right now it's reading -1 just because we're on a mannequin. But if you want to zoom in on a better waveform based on the ICP number, you can press scale, and it'll increase the scale. As you can see, went up to 20, 50, and you keep pressing the button until you actually do see a good waveform. We'll keep it where it's at -5 and 10. So the ICP is reading -1 on the Camino, but on the monitor that we slated to, it's reading 149. So it's really important that you calibrate it so that it is reading pretty much the same. So to do that, you have to press cal step, which I'm not pressing quite yet. I just have my finger on the cal step button, and you would go to 0, and you would press 0 ICP. So you do that both at the same time. So I'm going to start right now. I'm going to press 0 ICP and press cal step, and you'll see that it's reading 0 on the Camino. It's going to read 0 on the monitor. Once it reaches 0, you can let go of the cal step button, and now they both should correlate